this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. Well, guess what? This is it. This is it, the moment we've all been waiting for. I have received more requests over the past weeks and months for a specific discussion about one topic, and that is the topic of radiculopathy. Radiculopathy. And radiculopathy has now moved to the top of the to-do list, and today we're beginning a four-part series about the important topic of radiculopathy. And the reason radiculopathy is important for our consideration today and over the next several weeks is because many doctors are involved with the evaluation of spinal injuries. And so all of us need to get on the same page as to what it is we're talking about when we encounter an examinee who has symptoms that appear to be consistent with radiculopathy. And then number two, the second reason that a discussion of radiculopathy is both timely and important right now is because radiculopathy serves to illustrate several important principles involved with our evaluation of injured workers. And so in that sense, we can use radiculopathy basically as a metaphor for a discussion of many other conditions that we commonly encounter in the qualified medical evaluation. And so radiculopathy basically just serves as a metaphor for some of the important principles that I want to illustrate using radiculopathy as a specific example. Now, the AMA guides describe radiculopathy as an injury to a spinal nerve or a spinal nerve root. And so what we're going to talk about over the next 4 weeks is going to be a complete course on the physical exam of the spine and the spinal nerve roots. Now, we're going to focus our discussion primarily on the lumbar spine and the lumbar spine nerve roots because lumbar spine injuries occur with much more frequency than do cervical spine injuries, but I will give specific examples related to the cervical spine. But remember that our primary focus is going to be to illustrate principles of radiculopathy using the lumbar spine as our example. Now, over the next 4 weeks, here's what we're going to be talking about. Today is part one, and today I want to set some groundwork by giving you some definitions and some principles from the AMA guides that are going to serve as our ongoing themes as we investigate the condition of radiculopathy. And then, once that groundwork is established, I want to focus for the purposes of today's presentation on some general principles involved with the physical examination. And what I want to talk to you about today involves the nature of true objective findings. Or perhaps that could be stated as the true nature of objective findings. Or the nature of objective findings that are true findings, regardless of how we phrase it. What I want to go through with you today, in today's workshop, is separating the wheat from the chaff and separating subjective complaints from objective findings. And I want to talk about how to examine your examinee to discover and uncover the true objective findings. And we're going to use radiculopathy as an example. Now, once we establish these exam and philosophic principles in today's workshop, next week I want to talk to you about specifically how to perform the sensory exam, the motor exam, and how to do reflex testing. And I have a couple of bona fide and actual videos to include with next week's presentation. I have a video of a bona fide L5 radiculopathy with drop foot and motor weakness to resisted ankle and toe dorsiflexion in a bona fide examinee. So I want to demonstrate that as illustrative of the motor exam. And then I also have a videotape of a bona fide pathologic reflex known as the Hoffman's reflex. And I'm going to use the Hoffman's reflex as a general illustration principle of reflexes in general, and also to illustrate how reflexes are involved with true objective findings. And this is going to be a fabulous and fascinating insight for you if you have not already heard this discussion either from me and other blogs or videos or from another presenter. Then in week 3 we're going to talk about the sciatic nerve stretch test, and all of this is going to build philosophically, so by the time we get to sciatic nerve stretch test we can simply go through the stretch test with the foundation as to what the true objective findings are going to be for each of these associated physical examination maneuvers, and what would actually constitute or construe negative findings, meaning an absence of bona fide radiculopathy. We're going to talk about both sides of that coin. True objective findings that suggest or indicate radiculopathy, and negative findings which rule against or rule out bona fide radiculopathy. And then finally, in part 4 of this series, we're going to talk about consistency findings. In other words, if an examinee has bona fide radiculopathy, there should be several physical examination maneuvers that are consistent, that consistently indicate the same finding, and that is dysfunction of a spinal nerve root. And many doctors have not yet put together these consistency findings. For example, if an examinee has weakness on resisted ankle dorsiflexion, ankle and toe dorsiflexion, indicative of an L5 radiculopathy, we would not expect that examinee to be able to perform the heel walk maneuver, correct? We might expect this examinee to have a drop foot as they go through a gait, as we go through observing their gait during the physical examination. How could an examinee have weakness to resisted ankle and toe dorsiflexion and yet still be able to walk under the weight of their entire body weight without expressing a drop foot? How about an examinee with an S1 radiculopathy? We know that S1 innervates the gluteus medius muscle. Well, we would expect that examinee to have a Trendelenburg sign due to weakness of the gluteus medius. And many doctors have not connected the dots of the multiple innervations of these nerve roots to establish consistency findings. And I'm going to give you more consistency findings than you ever even thought existed. And the whole purpose of this program, my whole motive for presenting this program, is so that when you diagnose and provide for permanent impairment, for radiculopathy or any other condition, as I said, radiculopathy is simply a metaphor for us as illustrative of these principles. But when you diagnose and provide for permanent impairment for radiculopathy or any other condition, that you know that the examinee truly has that condition, and that you stand behind that condition, and you'll defend that opinion and conclusion by way of supplemental report and by way of deposition if the case should come to deposition. And it's interesting because I recall being in deposition myself, and I recall being interrogated by applicant and defense attorneys about my opinions and conclusions regarding radiculopathy. And you know what? I found that the attorneys asked questions that were actually very reasonable questions. But sometimes as doctors, we get lost in the trees and forget to see the forest. And we become so focused on our diagnostic minutia that we sometimes forget the big picture. And it's lay people like attorneys and claims administrators that have the insight to ask simple and reasonable questions that sometimes we as doctors have not thought of. And the point is to establish consistency with our physical exam, our diagnosis, and our permanent impairment rating that's a true and accurate representation of the examinee's true condition. It's my opinion that radiculopathy is way overdiagnosed and way overrated for permanent impairment, when in fact most of our examinees are suffering from non-verifiable radiculopathy at most. Okay? So we're going to talk about the definitive diagnostic criteria the definitive physical examination findings, and the definitive limitations and activities of daily living that qualify as radiculopathy. So to begin today's presentation, I want to go through several references with you in the AMA guides. So I encourage you to get your AMA guide so that you can follow along with me. These first 5 or 10 minutes of today's workshop are going to be critical that we get on the same page, because this will establish the theme over the next 4 weeks. So I'll give you a minute to go ahead and get your AMA guides, and I look forward to being back with you in just a couple minutes as we begin Part 1, Radiculopathy, the nature of true objective findings. Okay, I'm back with you now, and I have my AMA guides with me. Hope you have your AMA guides as well, because you're going to want to follow along with me as we go through several quotes from the guides themselves that will going to help us establish the principles and the philosophy of this program. So first thing I want to suggest to you is that if you spent any time in the AMA guides, you realize that the AMA guides have an overriding philosophy. The overriding philosophy of the AMA guides is that the AMA guides are concerned with true objective findings. They're concerned with measurements, angles, circumferences, degrees, inches. They're concerned with measurements and true objective findings and true objective testing in our physical examination. So I just want to read you a couple of quotes from the AMA guides that help solidify that concept for us as we move forward throughout this program. So if you have your AMA guides, first thing I would like to have you do is turn to page 2. Page 2 on the bottom, the AMA guides give us a couple of quotes. They say, this is the bottom of the left-hand column on page 2. It says, although the guides emphasize objective assessment, the guides emphasize objective assessment, subjective symptoms are included within the diagnostic criteria. So when it comes to spinal radiculopathy, when we diagnose spinal radiculopathy, the permanent impairment rating for spinal radiculopathy includes all of the subjective complaints of spinal radiculopathy. What are the subjective complaints of spinal radiculopathy? Basically, pain, numbness, tingling, burning, weakness, feelings of give way. All of the subjective complaints are included in the diagnostic criteria, provided that we can objectively verify the diagnostic criteria. Interesting. The guides are concerned with objective assessment. So if we can objectively document spinal radiculopathy, we can provide for permanent impairment, which includes all of the subjective criteria and all of the pain complaints. Okay? Very interesting. So that's one point. Second point, I'd like to have you turn to page 4. Again, bottom of the left-hand column says, in evaluating impairment, the guides considers both anatomic and functional loss. Anatomic and functional loss. Anatomic loss receives greater emphasis in the musculoskeletal system, as in measurements such as range of motion. Functional considerations receive greater emphasis in the mental and behavioral section. So with regards to the musculoskeletal condition of spinal radiculopathy, we're going to be concerned about our physical examination to uncover and discover the anatomic losses. The loss of spinal function, the loss of function of the spinal nerve roots. And we're going to spend a great deal of time talking about how to objectively assess and objectively verify these anatomic losses. Okay? Next principle I want to talk to you about is on page 10, which talks about, again, objective testing and objective criteria. This is at the top of page 10, second column. It says the guides uses objective and scientifically based data when available and references those sources. When objective data have not been identified, estimates of the degree of impairment are used based on clinical experience and consensus. Okay? So the guides, again, are largely concerned with objective data, objective verification, objective assessment, true objective findings. Okay? Now, here they talk a little bit about subjectivity again. And we mentioned subjectivity a minute ago. And it's important to keep in mind the distinction between subjectivity on the one hand and objectivity on the other hand. And just as a heads up to a recurring theme throughout this program, is I want you to always think to yourself, always ask yourself, what's objective here? What's objective here? This question will serve you time and time again in many, many circumstances. Always ask yourself, when you're flooded with a sea of subjectivity, always ask yourself, what's truly objective here? The objective findings will never lie. What's truly objective gives you great insight and helps you in the formulation of your opinions and conclusions. But here the guides talk a little bit about subjectivity. They say, subjective concerns including fatigue, difficulty in concentrating, and pain, when not accompanied by demonstrable clinical signs or other independent measurable abnormalities, are generally not given separate permanent impairment ratings. And many times doctors provide for permanent impairment ratings for radiculopathy based upon the subjective complaints. The subjective complaints of what? Of back pain and radiating lower extremity pain. But only when those subjective complaints are accompanied by independent and measurable abnormalities does the examinee qualify for a permanent impairment rating specifically due to radiculopathy. In the absence of independent measurable abnormalities, the examinee would simply qualify for non-verifiable radiculopathy. And it's my opinion, based upon the QME reports from doctors that I've had a chance to review, which is many, 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 in the hundreds, doctors do a poor job of documenting radiculopathy. And they diagnose and provide for permanent impairment due to radiculopathy when in actuality their physical examination supports only a permanent impairment rating for non-verifiable radiculopathy at most. Okay? So let's summarize that. The guides are concerned with objective tests, objective assessment, and objective findings, and they downplay or diminish, although they don't totally negate, the importance of the subjective findings. So throughout the remainder of today's discussion, we're going to talk about the nature of true objective findings and the nature of true objective findings as they relate to radiculopathy. Okay? Okay, a couple more quotes and we'll get on to just that discussion. Let's move now into the Spinal chapter on page 375. This is in chapter 15. And this is fascinating. This is fascinating. On page 375, second paragraph of the second column, it says, it's talking about the spinal exam. We're in chapter 15. It's talking about the principles of assessment in section 15.1. This is the principles that the AMA guides require us to rely on in our assessment of spinal impairments. It says, the physician should record and discuss any physical findings that are inconsistent with the history. That makes sense. It says, many physical findings are subjective. That is, potentially under the influence of the individual. It's important to appreciate this and not confuse such observations with truly objective findings. This is a powerful, powerful quote and statement, and it contains so much that we should review it. It says, many physical findings are subjective. Let me give you an example. You're at a deposition, and the defense counsel says to you, well, doctor, what was your objective findings for radiculopathy that led you to diagnose and provide for permanent impairment for radiculopathy? And you, being the sharp, prepared, well-researched doctor that you are, you say with supreme confidence, well, they had a positive straight leg raise test. And the defense counsel asks a very reasonable question, and that is, doctor, what is a positive straight leg raise test? And you, in all your wisdom and experience, say, well, when I raised the examinee's leg up at 45 degrees, they complained of pain in the exact distribution of the L5 nerve root. I mean, it went right down to their great toe. It went to the tops of the dorsum of the foot, and it was in exact distribution as described in the AMA guides in the region of the L5 nerve root. Boom, you feel. You feel you hammered that question. And the defense attorney says, which is a very reasonable question, well, doctor, isn't that just a subjective complaint? That the examinee reported pain in a certain distribution? That's not the same as the examinee had pain in that distribution, is it? And you realize that the defense attorney has a very good point. You construed a subjective complaint on an objective test. See, we consider these to be objective tests, straight leg raise, we consider these to be objective tests, but you considered a subjective complaint on an objective test to be a true objective findings. And the AMA guides use this exact phrase. They use this exact phrase. I'm not making this up, although I thought I did. They say, it's important to appreciate this, that many physical findings are subjective. They say it's important that we appreciate this, but not confuse such observations with truly objective findings. They use the phrase, truly objective findings. So that introduces a new concept, the concept of true objective findings. Simply a subjective report of pain on an objective test is not a truly objective finding. The guides, in their immaculate wisdom, counsel us and direct us through our physical examination, and they advise us not to be confused by subjective complaints. Our job, our mission, our duty, our obligation is to seek the true objective findings. And this whole program is about the true objective findings associated with radiculopathy. Okay? Okay. So, let's move on. Having established that as our background, we're focused on true objective findings. Let's talk about the nature of true objective findings. And in order to establish a little foundation and lay some groundwork for true objective findings, I think it's important that we talk ever so briefly here, first of all, about pain and pain in general. And this is going to give us some insight as to how the body responds truly to pain. And isn't that the purpose of our objective physical examination maneuvers? Most of our physical examination maneuvers have as their purpose the reproduction of pain. Well, when we're confronted with pain, there are typical responses that the body goes through. So let's talk a little bit first about pain to lay the foundation for our theory on true objective findings. Okay, a couple of definitions of pain. This is from the International Association for the Study of Pain, and it's also the same definition that the AMA guides cite for pain on page 566. They say that pain is, quote unquote, an unpleasant sensory and emotional experience arising from actual or potential tissue damage or described in terms of such damage. It's a unpleasant sensory and emotional experience arising from actual or potential tissue damage or described in terms of such damage. So sensory and emotional. Okay? Now the American Academy of Pain Management has modified this definition to more fully consider the emotional aspect of the pain and to more fully separate the sensory and emotional aspects. So the American Academy of Pain Management says that pain is an unpleasant sensation and the emotional response to that sensation. Here they emphasize the emotional response to the sensation. And I wonder if you've ever heard those descriptions wherein motivational speakers or sales trainers describe an emotional and a logical component to selling to people, or an emotional and a logical component of people's personalities in general. Let me illustrate. You may have heard it said that people are 80% emotional and 20% logical. Have you ever heard that? I heard that for the first time listening to some sales training seminars by Zig Ziglar probably 3 decades ago. And I thought, wow, people are largely emotional. That is what was the theme of his lecture. Well, I've also heard it said, and maybe you've heard it said, that no, people are 90% emotional and 10% logical. Well, I recently was listening to a psychologist, Martin Seligman, PhD is his name, and I heard him say that people are 100% emotional and 0% logical. In fact, their logic, which comes later, their initial responses, initial reactions, initial statements, are 100% emotional. And their logic later becomes contorted to coincide and to be consistent with the initial emotional response. According to Seligman, PhD, people are 100% emotional. So we can expect for our examinees to lay on the emotional aspect of their pain and to downplay or minimize or understate or underdevelop the sensory aspect of their pain. And so it's the emotional aspect of the pain that's largely subjective. We're after the nature of the true objective findings, the true sensory disturbance, the true sensory experience, the true painful experience associated with the pain or the condition. And we need to be able to separate out which part of the subjectivity is simply emotional. And I'm going to show you exactly how to do that. Okay? So we have 2 definitions of pain, one of which describes pain largely in terms of an emotional response to pain. Finally, Merriam-Webster says, pain is a basic bodily sensation induced by a noxious stimulus. It's received by naked nerve endings and is characterized by physical discomfort, such as pricking, throbbing, aching, burning, numb, pain, stabbing, shooting, lancinating, lightning, electrical, all these physical discomforts, and typically leading to evasive action. Typically leading to evasive action. So by definition, pain leads to evasive action. And this is critical for our understanding of the nature of true objective findings. Evasive action. Pain leads to evasive action. Our physical examination maneuvers that reproduce pain should demonstrate some form of evasive action in the presence of a truly objective finding. Isn't that fascinating? Let's develop this idea and this theme a little bit. Okay? Now, the AMA guides are quite interesting. The AMA guides are quite interesting. So, pain leads to evasive action. Are there references in the AMA guides that describe evasive action? Well, there's at least one excellent one. And there's many more. I just have selected one for us. So if you have your AMA guides, I'd like to have you turn to page 504. Now, here we're in the upper extremity chapter. We're not in the spine chapter. But we're talking on page 504 about shoulder instability testing. Shoulder instability testing. What does that got to do with spinal radiculopathy? Well, they share similar principles. And our physical exam is going to share similar principles regardless of what body part we're examining. Now, with regards to the shoulder, the AMA guides are describing what's known as the shoulder apprehension test. The apprehension test. And many of you learned about this test in your undergraduate or graduate training. I learned about it. And what the apprehension test is the apprehension maneuver is a test that's designed to reproduce or simulate a potential subluxation or dislocation of the head of the humerus from the glenoid fossa of the shoulder. If the examinee has suffered prior dislocations, they will have instability of the shoulder, and this particular maneuver can simulate or reproduce a recurrent dislocation or subluxation of the shoulder. So as you go through this shoulder apprehension maneuver, if the examinee suspects or feels or senses, and much of this is reflexive, it's not cognitive, it's reflexive. If the examinee senses that the shoulder could sublux or dislocate, they will wriggle or maneuver or reposition themselves in such a way to minimize the potential subluxation or dislocation. They'll move in such a way to reestablish congruity between those joint surfaces. It's called the apprehension sign. The apprehension sign is simply an evasive action away from the pain of a shoulder subluxation or a shoulder dislocation. Isn't that incredible? Okay, now what do the AMA guides say about this? They talk about the apprehension sign on page 504. They say, the anterior apprehension test is performed by applying external rotation as the shoulder is held in 90-degree abduction. If the test is positive, in other words, a true objective finding for the anterior apprehension test is when the individual fears that the humeral head will slide out, causing pain. Muscular defense against the motion is usually present. Muscular defense. The muscular defense is simply a form of evasive action. The muscular defense, interestingly, and this is a principle, the muscular defense is reflexive. It's not cognitive. It's a reflex. It's a spinal mediated reflex. Pain, motor control, motor output to wriggle, reposition, maneuver in such a way to reestablish contact. It's an evasive action reflex that manifests in the form of muscular defense. This is a fascinating principle, and it guides us through our physical examination as we search for the elusive, truly objective finding. Okay? So we have examples of true objective findings in the form of evasive action away from pain and muscular defense away from pain. Now, what are some other examples? What are some other examples that you can think of evasive action during the physical examination? Well, we talked about the shoulder apprehension test. Have you ever heard of the patellar apprehension test? The patellar apprehension test is the same thing with potential subluxation or dislocation of the patella. Okay? The examinee will give you what they call the apprehension sign, which is like which is totally reflexive as they reposition themselves to reestablish congruity between the joint surfaces of the patella and the trochlea of the femur. It's reflexive. It's a muscular defense. It's an evasive action. What about Bacotti's sign? Have you ever seen an examinee present with Bacotti's sign? Bacotti's sign, also known as the abduction relief sign, shoulder abduction relief sign, is when an examinee comes into the office with their hand on top of their head. The purpose of this is to reduce traction on cervical spine nerve roots in the case of a hot and active cervical spine radiculopathy. This position is an evasive action away from this position here, which applies traction to sensitive nerve roots. This is a true objective finding. What about the Neary's bowstring sign? Neary's bowstring sign. Neary's bowstring sign is a reflexive withdrawal due to flexion of the knee to introduce slack into the lumbar spine nerve roots when those nerve roots are tensioned and traction during the straight leg raise maneuver. So with the straight leg raise maneuver, when the examinee feels pain through those hot nerve roots, they will reflexively bend at the knee to relieve the pain, to evade the pain, to get away from the pain, to minimize the pain. It's a form of evasive action away from the pain. Isn't that incredible? True objective findings include an evasive action away from the pain. Now, these examples, what we've just talked about, the shoulder apprehension test, patellar apprehension test, the Bacotti's sign, the Neary's bowstring sign, and there are many others. And we're going to get into these with regards to radiculopathy in session 3 when we get into the sciatic nerve stretch test. But these examples are illustrative of a more general and larger principle. And the larger principle is a reflex known as the Flexor withdrawal reflex. And I love reflex testing in general because reflex testing is one of the truly objective tests that we have. Reflexes are totally objective. So despite what the examinee says in terms of all the subjectivity, when we test reflexes and we find normal reflexes tell us that a lot of structures are functioning properly and correctly. You need to have a lot of structures properly functioning in order to have normal, brisk reflexes. So I love reflex testing. Well, we can use the concept of reflex testing in our pursuit of true objective findings by understanding the flexor withdrawal reflex. Now, you probably studied the flexor withdrawal reflex back in neurophysiology, back in your graduate training. And let me just refresh your memory that when we talk about the flexor withdrawal reflex, typically the examples that we use include touching our finger to a hot stove or perhaps even stepping on a sharp tack. In both of those instances, when you touch your finger to a hot stove, that activates thermoreceptors thermoreceptors on the tip of your fingertips, which are richly populated with thermal and other types of sensory receptors as well. And we'll talk about all the different sensory receptors in our next session when we get into sensory testing. But those thermoreceptors fire action potentials, fire action potentials, taking you back here to neurophysiology. Those action potentials run up the peripheral process of this neuron, run up the peripheral process, up to the dorsal root ganglion, where they're right outside the spinal cord. The central process continues to propagate the action potential. The peripheral process makes a synapse within the spinal cord with a motor output neuron. In this case, the motor output neuron is in the C6 level of the spine, where there's innervation to the biceps muscle. These C6 fibers travel in the musculocutaneous nerve, and when these thermoreceptors are activated, they cause an instantaneous and reflexive withdrawal, flexion withdrawal, activation of the forearm flexor, which is the biceps brachii, a flexor withdrawal reflex to pull the fingers away from the painful stimulus, which is the hot stove. It's an evasive action against the pain. It's an evasive action. Evasive actions are simply manifestations of the flexor withdrawal reflex. So throughout our physical examination, regardless of the body part we're examining, and this is where this program applies not just to neuromusculoskeletal specialists, but this applies to the entirety of our physical examination across specialties and across body parts. True objective findings involve some form or some manifestation of the flexor withdrawal reflex. And when it comes to spinal radiculopathy, we're going to be searching and observing for examples of the flexor withdrawal reflex. It's a form of evasive action. It's what the AMA guides refer to as a truly objective findings. And it's the presence of the flexor withdrawal reflex is what separates the subjective complaints of positive findings from true objective findings. So doctors, let's review. Let's review. This is an important session that establishes the philosophy for the remaining 3 sections. It's my opinion that spinal radiculopathy is overdiagnosed and it's overrated and provided for permanent impairment when it actually does not exist. Because many times we rely on the examinee's subjective complaints to contribute to our diagnosis. But according to the AMA guides, we should not be confused by simply subjective complaints, but rather we should be focused on true objective findings. And I've read many doctors' QME reports wherein the diagnosis and the permanent impairment rating really are not supported by true objective findings. And I'll tell you what, if I was a defense attorney, I would attack those reports. And I would attack those opinions and conclusions. And you would too. You would too. That would be a normal and natural defense against what otherwise is an overinflated diagnosis and an overstated and overinflated permanent impairment rating. So the key to properly diagnosing spinal radiculopathy begins with an understanding of the nature of true objective findings. And true objective findings involve some form of evasive action, typically which is manifested by some form of the flexor withdrawal reflex. Now we're going to apply these concepts next week to the sensory exam, the motor exam, and reflex testing. We're going to apply these principles in our 3rd session to the sciatic nerve stretch test, which we can generalize and analogize to all of the nerve root tension signs, including those in the cervical spine. And then finally, we're going to elaborate and build on these principles, these same principles, in our 4th session when we talk about consistency findings throughout the physical examination. So doctors, I hope this has been enlightening for you. I'm sure this has probably shaken your paradigm quite a bit. I remember talking about this very concept recently at a QME relicensure seminar, and one of the attendees in the seminar raised their hand and they asked me a very good question, and they said, well, isn't it possible for the examinee to have actual pain without some form of evasive action, without some manifestation of the flexor withdrawal reflex? And I said, so give me an example. And he said, well, with a straight leg raise test. And I said, do it on me. And so I laid down on the table and he took my leg and he raised it up to 45 to 60 degrees. And I looked at him and I said, yes, I have pain. The pain is down the back of my leg. It goes into my big toe. And there was no true objective finding. And he asked, isn't it possible that there could actually be pain without the true objective finding? And I admitted to him that yes, indeed, it is possible. However, that's a subjective finding only, and it gives you some indication as to the true severity of the positivity of the test. It gives you some indication as to the true severity of the pain. It gives you some indication as to the true impairment or the true dysfunction of that nerve root. It would be like touching your finger to a hot stove. You wouldn't be able to keep your finger on that hot stove because the response gives you an indication as to the temperature of the stove. If you can keep your finger on the stove, it tells you that the stove isn't that hot. It gives you an indication as to the true temperature of the stove. And we all agreed that that made a lot of sense.